Page 198. Inside, outside, the sounds of a partially obstructed airway. A partially obstructed airway can often be identified by the sounds of limited air movement. Understanding these sounds can help you better understand the pathophysiology of the obstruction. Stridor. Stridor is typically caused by a severely restricted air movement in the upper airway. As air is forced by pressure through a partial obstruction, a high-pitched, sometimes almost whistling sound can be heard. Typically, stridor indicates a severely narrowed passage of air and suggests near obstruction. In stridor, the obstruction can be caused by a foreign body, such as a toy, or it can be caused by swelling of the upper airway tissues, as in an infection. Hoarseness. Voice changes, such as stridor, often reflect a narrowing of the upper airway passages. Voice changes are often useful in assessing an ongoing airway issue. For example, if a person whose airway is swelling after a burn, you may note a normal voice to begin with, but a raspy voice as the swelling builds up around the vocal cords. The development of hoarseness is often an ominous sign. Snoring. Snoring is the sound of the soft tissue of the upper airway creating impedance or partial obstruction to the flow of air. Many persons normally snore while asleep, but snoring in the case of an injury or illness can often indicate a decrease in mental status, such that airway muscle tone is diminished. It is also an indication that the airway needs assistance to stay open. Gurgling. Gurgling is the sound of fluid obstructing the airway. As air is forced through the liquid, the gurgling sound is made. Common liquid obstructions include blood, vomit, and other airway secretions. Gurgling is a sign that immediate suctioning is necessary. Patient care. The airway. When signs indicate an inadequate airway, a life-threatening condition exists, and prompt action must be taken to open and maintain the airway, as explained next. Core concept: how to open an airway. Opening the airway. Assessing the airway will be one of the highest priorities of your assessment. When an airway problem is detected, it must be dealt with immediately. For most patients, the airway can be assessed by simply assessing their speech. In a person with a diminished mental status, the procedures for airway evaluation, opening the airway, and artificial ventilation are best carried out with the patient lying supine, flat on his back. Scan 9.1 illustrates the techniques for positioning a patient found lying on the floor or ground. Patients who are found in positions other than supine or on the ground should be moved to a supine position on the floor or stretcher for evaluation and treatment. Any movement of a trauma or injured patient before immobilization of the head and spine can produce serious injury to the spinal cord. If you suspect an injury that could have resulted in spinal trauma, protect the head and neck as you position the patient. Airway and breathing, however, have priority over protection of the spine and must be ensured as quickly as possible. If the trauma patient must be moved to open the airway or to provide ventilations, you will probably not have time to provide immobilization with a cervical collar or head immobilization device, but instead will provide as much manual stabilization as possible. Use the following as indications that head, neck, or spinal injury may have occurred, especially when the patient is unconscious and cannot tell you what happened or respond to assessment questions. Mechanism of injury is one that can cause head, neck, or spine injury. For example, a patient who is found on the ground near a ladder or stairs may have such injuries. Motor vehicle collisions are another common cause of head, neck, and spine injuries. Any injury at or above the level of the shoulders indicates that the head, neck, or spine injuries may also be present. Family or bystanders may tell you that an injury to the head, neck, or spine has occurred, or they may give you information that leads you to suspect it. You must open and maintain the airway in any patient who cannot do so for himself. This includes patients who have an altered mental status, including unconsciousness, or who are in respiratory or cardiac arrest. Insertion of an oral or nasal airway and suctioning may be required to maintain a patent airway. As stated previously, most airway problems are caused by lack of muscle tone in the muscles that keep the airway open. As control over these muscles diminishes, muscles such as the tongue relax and allow the airway to be obstructed. Often, position contributes to this problem. As the head flexes forward, the tongue may slide into the airway, causing the epiglottis to obstruct the airway. If the patient is unconscious, the tongue loses muscle tone and muscles of the lower jaw relax. Since the tongue is attached to the lower jaw, the risk of airway obstruction is even greater during unconsciousness. The basic procedure for opening the airway to help correct the position of the tongue and therefore move the laryngeal tissues, such as the epiglottis, out of the way of the glottic opening. The basic procedures for opening the airway help to correct the position of the tongue and therefore move laryngeal tissues, such as the epiglottis, out of the way of the glottic opening.